a cardiac illness. I'm sure most of us don't have much experience in dealing with cardiac illnesses in a palliative care setting. So today we'll be getting insights from two experts as usual. One is Dr. Shoba Nair and the second one is Dr. Puneeta Sharma. Dr. Puneeta is the chair for medical subspecialties at the Valley Medical Group in New Jersey. She's a board certified in internal medicine and hospice and palliative care. I think since 2019, she's been looking after rheumatology, GI, endocrine, dermatology, and so many specialties across the health system. And she's a program director for internal medicine as well as hospice and palliative medicine. Sorry. So she had given her lecture in the last season of refresher course, and there were good feedbacks from that. We had great learnings that time also. The second faculty for today is Dr. Shoba Nair. So glad to see you, Dr. Shoba, again here in this group. And she is currently the professor of palliative medicine in Amrita Institute of Palliative Medicine, Kochi. She's a former consultant in Sheffield Teaching Hospitals, UK. And she was working with St. John's for a long time in the Department of Palliative Medicine. And she was former editorial board in IJPC. And she has special interest and experience as well in working with many areas, and not just in cardiac, but many non-cancer palliative care areas. I welcome you both for today's session. We have around somewhere around 35 to 40 participants logging in us. And they are all working in palliative care for the last few years, probably. So welcome you both for this very interactive session.
Hi, can you hear me now?
Yes, Dr. Puneeta.
Yes.
And just remind me, what screen are you seeing? Are you seeing the slideshow mode, or are you seeing the other mode?
We are seeing. You can. It's a presenter mode we have put in. We can see the upcoming slide also with the notes.
Okay, so hold on 1 second. Just 1 second. India, and good morning. So good evening, everyone in India, and good morning to everyone who's attending from the other side of the world. So really excited to be here to sharing, what we've been doing with cardiac care in US. So like, the introduction was provided. I have been working in the field of palliative care since about 2010. And it's really been, an eye-opener to see how the practice, as well as the number of diseases now that we are taking care of, or the number of individuals that we are taking care of, and the modalities that they present with, it's just growing and increasing. Initially, when the practice started, we used to see oncology patients. Predominantly, I would say 80 to 90% of the patients that we would treat or would come across our way would be oncological patients. But now we are seeing all sorts of diseases from, ranging between oncology, cardiac, neuro, and everything. All right. Are you seeing the second slide or no?
No, ma'am. Only the first.
We are on the first slide.
And what are you seeing? Are you just seeing the title slide, the refresher course?
Yes.
Okay. Let's see. Why is this not advancing? How about now?
No, ma'am. Still the first slide only.
Okay. What about now?
Yes, that's perfect.
All right. So our objectives for today is to understand the role of palliative care interventions in patients with cardiac diseases, as well as explore the feasibility of setting up some guidelines for implementation of palliative care interventions in patients with cardiac diseases. So worldwide, if you look at it, there are multiple conditions that would benefit from palliative care interventions, and cardiovascular diseases account for about 38% of those diseases. What's the disease burden for cardiovascular diseases in India? India houses about 1/6 of the world population. Cardiovascular diseases, they account for #1 reason for mortality in India. 24.3% of the deaths in 2000 were attributed to some form of cardiovascular disease, whereas the number is now increasing to 32% of the deaths. And mortality is becoming higher in females than males. To go a little bit deeper into this, there is certain differentiation that's emerging between what you see in the Western population versus what you see in the Indian population. So you're seeing that there is early age of onset, there is rapid progression, as well as there is high mortality rate. It was fascinating to see that the highest rates of cardiovascular disease burden was in Kerala, Punjab, and Tamil Nadu. So really the amount of disease prevalence as well as the incidence and the burden is increasing. So which means, we need to be prepared to be able to meet the needs of this population. So just a brief snapshot of what the cardiovascular disease spectrum contains. It could range anywhere from your regular coronary heart disease, CVAs, peripheral arterial diseases, rheumatic heart disease, congenital heart disease, DVTs, PEs. Heart failure basically is one of the final common pathway, which is responsible, and that happens as a result of all of the cardiac insults. So it's a progressive condition in which the heart muscle, it's unable to pump enough blood to meet the body's need for blood and oxygen. It's a clinical diagnosis based on history and exam. And what happens here is that there are structural or functional cardiac disorders which interfere with the ability of the ventricle to either fill or eject optimally. So as a result of this abnormality, compensatory mechanisms, they come into place, and that includes enlargement of the heart, increase in the muscle mass, faster pumping action of the heart. Blood vessels may eventually become narrow, and there is diversion of blood from the less important organs to the more important ones. And once these compensatory mechanisms, they exhaust, that's when the individuals start developing signs and symptoms of heart failure. So what are some of the risk factors? I mean, the list is here, and it's ever increasing: CAD, hypertension, previous MI, valvular heart diseases, congenital heart diseases, lung disease, diabetes, anemia, arrhythmias. We talked a little bit about the pathogenesis of heart failure, basically involving increased overload. And then there is ischemia related dysfunction. There is ventricular remodeling. There's excessive neurohumoral stimulation, and basically accelerated apoptosis and genetic mutations. Heart failure generally classified into two types: heart failure with preserved ejection fraction, as well as heart failure with reduced ejection fraction. The one with preserved ejection fraction, mostly seen in females, older adults. What it involves is a stiff heart, has a relatively better prognosis with medical management. Heart failure with reduced ejection fraction is typically dilated heart and confers a poor prognosis. I think everyone must be familiar with the New York Heart Association heart failure classification, which ranges from class 1 to class 4. And basically this is based on any limitation of physical activity and how severe that is. So class 1 being no limitation, and class 2, 3, and 4 representing increasing degrees of physical activity limitations. According to the American College of Cardiology and American Heart Association heart failure classification, this takes into account the structural and, are you still seeing the slide is still on, correct?
Yes.
Okay, so according to the American College of Cardiology and American Heart Association, the staging is based on whether you are at risk for heart failure or you already have evidence of structural heart disease. And stage C involves people who have already developed clinical heart failure. And stage D is really advanced refractory heart failure, which is requiring advanced interventions. Some of the common symptoms associated with heart failure, shortness of breath, progressive, and limitation of functional activity, unable to do activities of daily living as the disease progresses, orthopnea, PND, fatigue, lethargy, exercise intolerance, weight loss, loss of appetite, extremities become cool, mental status changes happen, and eventually depression, anxiety, and isolation sets in. Some of the signs in late stage heart failure involve increase in your heart rate, edema, increased jugular venous pressure, abnormal lung sounds, S3 gallops, cool extremities, mental status changes. And on the x-rays, you might see pleural effusions or cephalization of vessels or curly B lines and increased cardiothoracic ratio, cardiomegaly. So in general, management of heart failure, it involves lifestyle changes, medication management, and certain advanced devices and surgical procedures. So lifestyle changes involve, exercise, weight loss, smoking cessation, limiting fluid and caffeine intake, abstinence from alcohol, heart healthy diet, ensuring that you're managing your stress, monitoring of blood pressure, adequate rest, seeking support groups, keeping your vaccinations up to date, and avoiding tight clothing. The medication chest includes anything from diuretics to ACE inhibitors to ARBs, beta blockers, aldosterone antagonists, hydralazine, isosorbate dinitrates, your anticoagulation if indicated, cholesterol lowering medications, and digoxins. Some of the advanced procedures that can be used in advanced heart failure involve defibrillators to counteract your arrhythmias, cardiac resynchronization therapy for establishing synchrony of the ventricles, left ventricular assist devices to replace a damaged heart. A PCI may be needed in case you have coronary artery disease with blockages, and a bypass may be needed to reroute blood supply around a blocked artery, or valve replacement for defective or diseased valves. So this is a slide from the American Heart Association and basically walks you through, how you manage heart failure from between stage A, B, C, and D. And in general, if you look at it, when you're at risk at that point in time, the interventions are more directed toward lifestyle changes, so as to prevent the progression to stage B, C, or D. Now, you can continue medication management based on, whatever are the risk factors that you have or comorbid conditions that you have. So if you have hypertension, ensuring hypertension control. If you have CAD, ensuring, the CAD is appropriately managed. And LVADs and advanced cardiac therapy, that comes in when, your heart disease is becoming severe. We talked a little bit about pharmacology, don't need to go into detail here. These are some of the links that you can see for, how the cardiac resynchronization therapy works and how does the ICD therapy works. LVADs are now being used as a destination therapy by itself. Before, they used to be a bridge therapy before somebody could get a cardiac transplantation. But if you're not a candidate for cardiac transplantation or in areas where cardiac transplantation is not available, LVADs could be considered. So think of the LVAD as, one of the mechanical devices which connects to your left ventricle and then basically does the work of the left ventricle, pushes the blood out into the aorta and goes into the other parts of the body. Has made life a little bit practical because you can wear this device and still continue to do your regular activities. There are, complications that come along with this, bleeding, clot, making sure you have to ensure that your battery is always on. So, but generally, what we have seen is people are able to live up to 6 to 7 years with this device. Talking about the natural trajectory of heart disease. So as you'll see in this graph, the trajectory generally involves a chronic illness which is progressing with periods of exacerbations requiring repeated hospitalizations, which is followed by recovery and really prolonged periods of significant disability. And these periods of disability may be interrupted by acute exacerbations, and death may happen during an exacerbation. I can tell you I've come across multiple situations where patients continue to have repeated hospitalizations. And during one of those hospitalizations, when family members thought that this was going to be another one of those, patients actually acutely declined and passed away during that hospitalization. So really important to have a conversation about the typical heart failure trajectory when we are speaking to our patients and their families. What are some of the predictors of poor outcome? Advanced age, advanced heart failure. If there is a severity of reduction in the left ventricular ejection fraction, reduced cardiac index, if you have a concomitant diastolic dysfunction, if you have low peak oxygen capacity with maximal exercise, and if there is evidence of reduced tissue perfusion. Oftentimes I've seen advanced heart failure patients presenting with altered mental status because now they're no longer able to oxygenate their brains to the degree that they used to do before. and now they are more sleepy, or they may be confused. There may be varying degrees of encephalopathy that you may come across in these patients. Additional predictors include lack of improvement in hemodynamics with medical management. So, you've exhausted your chest of medical management involving diuretics, beta blockers, and all of the medications that we talked about earlier. And now coming down to a point where, pressors or vasopressor medications like inotrope support is needed. Prognosis is seen to be worse with diabetes and ischemic cardiomyopathy. Third heart sound, again, a poor predictor. Hyponatremia is another poor predictor. Elevation of your BNP and catecholamine levels. These are also poor predictors of heart failure. And multiple hospitalizations, that's indicating that, things are not going well at all. And, time to have conversations about what matters most to the patients. The problem is one of the key prognostication challenges that I find is that the current models that exist now, they may not be applicable to your population. So, Seattle heart failure model and the heart failure risk model, these were, models that were based on a certain population. So they may or may not be applicable to the population that you may be dealing with. So the population-based risk may not be the same as the individual risk. So I did come across a National Heart Failure Registry. This is something new, that I learned that now exists in India. So maybe an opportunity there for people to look into, if a similar kind of modeling could be developed. Right now, my understanding is that this registry involves, studying about, what's the prevalence and what are some of the interventions and what is being done about heart failure. Eventually, if the database becomes, more and more, then, an opportunity lies to develop similar prognosticating models there. Another thing that I came across was, I didn't put the link over here, is Statista. Now, I'm not sure, of the local dynamics over there, because it's been, many, many years since I've not been in touch, with really the medical management that's happening with all of these conditions in India. But something to be aware about, and maybe that's a database that you may find helpful as you study more about heart failure and as you develop interventions to be able to tackle this ever expanding disease. So I want to spend a little bit of time in talking about what can we do as palliative care specialists for heart failure, because that's really the crux of the situation. I mean, some of us may be cardiologists. I'm definitely not a cardiologist, but what I can throw in is the perspective from a palliative care physician as to how we can influence or impact each of these domains when we see a patient with heart failure or cardiovascular diseases. So the morbidity and the mortality, which is associated with CHF, it really impacts our patients' and caregivers' quality of life. And individuals, may not be able to enjoy foods of their choice. They may not be able to socialize. It becomes difficult to do activities of daily living because now they no longer have the functional capacity. They now have leg edema. They have shortness of breath. They need to use the restroom repeatedly because they're on diuretics. They may be tired all the time. Their cognition may be impaired. So all of this leads to frustration and a feeling of being a burden, both for the patient, and then it's a burden for the caregiver also. So all of this can eventually impact your mental health, lead to anxiety, lead to depression. And patients and families or their caregivers, they really start grieving this loss of normalcy. So caregivers are often impacted by physical, emotional, and financial distress, and they just don't know what to do and what to expect and how best to support their loved ones. So what we can do is, as palliative care teams, we can utilize an interdisciplinary approach to provide relief from the symptoms and stresses associated with cardiac diseases as well as CHF, and improve the quality of life for these individuals who are suffering from these diseases. So this is a framework that that exists for or that has been taken from the National Quality Forum, and this framework provides preferred practices for palliative and hospice care. And so if you go over it one by one, the physical symptoms, what are some of the symptoms that palliative care patients experience? So physical symptoms like dyspnea, pain, fatigue, nausea, these may be experienced by these patients. And what do you do about them? So essentially having a clear communication strategy on why these symptoms exist and what are some of the mechanisms by which we can alleviate these symptoms will help patients and caregivers get a better understanding of their symptoms and help them better manage those. So, and our focus here is to be able to develop self-management skills in the patients as well as the caregivers, so that we can partner with them in their own disease progression. So dyspnea. So first and foremost, focusing on treating the volume overload with your regular medication chest. So disease-directed treatments for heart failure or whatever other risk factors for heart failure here. The non-pharmacological measures that can be used here are examples like facial cooling, use of fan to blow air on the face. Oral short-acting opioids can be used for outpatient management of dyspnea. And let's say if the patient is using these medications frequently, then sustained release opioids can be used. If patients develop acute respiratory failure towards the end of life, they may benefit from IV infusion of opioids. And also ensure that we do see if anxiety is a contributing factor, because in that case we may need to prescribe medications or interventions for managing anxiety. Pain can be related to fluid accumulation, ischemia, or other comorbidities, for example, diabetic neuropathy. So again, disease-directed treatments, use your pharmacological measures, whatever that you can. But other non-pharmacological therapies that can be used are thermal or cooling modalities, topical agents. If antidepressants are indicated, those could be used. Anticonvulsants, if indicated, those could be used. And again, opioids for ischemic pain, and ensuring that if there is a neuropathic component, then we are managing that pain accordingly. CBT, cognitive behavioral therapy, can be used for self-management of pain as well. Generally, we tend to avoid NSAIDs because of risk of fluid retention. So the next symptom, may be fatigue due to heart disease, medications, physiological changes that are happening in the body, anemia. You're not able to sleep, feel tired throughout the day. So again, efforts directed towards treating the underlying issue, and then reconciling medications according to risk versus benefits. Meaning, if somebody has such advanced heart failure, does it really make sense to give them, diuretics towards the end of the night, where now they have to, disrupt their sleep towards the night, and then, keep using the restroom, and they're not able to, sleep properly, versus, if that medication can be given somewhat earlier during the day, so that at least the peak effect, happens during the earlier part of the day versus latter. So if non-pharmacological measures such as organization of daily activities have not helped, then ensuring that, if patients are sleeping propped up because they're not able to lie down flat, so that they can now sleep better, and avoidance of screen time before sleeping, doing some relaxing activities prior to bedtime. Sleep adjuncts like melatonin and sedative hypnotics can be used. IV inotropes have questionable benefits in this setting, and psychostimulants, can be considered for very selective group of patients. Nausea due to ascites, abdominal distension, low cardiac output, all of this can contribute to nausea. And optimization of, again, decongestive therapy and addition of antiemetics such as ondansetron, haloperidol, metoclopramide, and prochlorperazine. These medications can be used for symptomatic relief. Psychological symptoms, anxiety, depression, again, common in patients with cardiac diseases, and they also run the risk of exacerbating other symptoms such as pain, insomnia, dyspnea, and fatigue. CBT, cognitive behavioral therapy, and relaxation training are useful. SSRIs, SNRIs, tricyclic antidepressants, benzodiazepines, psychostimulants are additional therapies that can be considered after you weigh the risk-benefit profile with underlying comorbidities. As far as the structure and process of care, the statistics are really mind-blowing here. Less than 1% of patients in India have access to palliative care, and India ranks at the bottom of the quality of death index.
I'm sorry to interrupt. I think the slides are not moving.
No, so this slide is not moving.
All right, perfect.
Yeah, so we're going over all of these domains one by one. So in, like I was talking about the structure and process of care. So, the access to palliative care is really limited at this point in time. I did see that, joint position statements have been developed by the Indian Association of Palliative Care as well as the Academy of Family Physicians, which does provide recommendations on developing a community-based palliative care program throughout India. And the position statement with the Indian Society of Critical Care Medicine, as well as the Indian Association of Palliative Care, that is now able to provide practical procedural guidelines for improving end-of-life care within an ethical framework. Cultural aspects, again, really, really important to understand how culture is impacting an individual and family's reaction to serious illnesses and decisions about end-of-life care. So basic dimensions in end-of-life care that vary, culturally, are how bad news is communicated, and who are the decision makers, and what is the attitude towards advanced directives and end-of-life care. So we as providers must have a clear understanding of how these influence an individual's behavior, attitude, preferences, as well as decisions around end-of-life care. So for example, a family may not want an individual to know about the terminal diagnosis, or there may be a taboo about talking about death. So, in some parts of the society, whereas in the Western world, autonomy is the prime or the central reason around which the delivery of care is based on. So, there is no way that we cannot let the patient know what is happening to them. It's the patient's choice whether they want to hear the information, yes or no, but we cannot be talking about the patient with the family without the consent of the patient, and without letting them know that, this is what we are going to be talking about. Similarly, collective decision-making is the norm in some families, and autonomy is valued in others. Some individuals may avoid public display of emotion, even when suffering, whereas others, they view illness as a test of their faith. Continuation of life-sustaining treatments may be considered as disturbing the natural cycle of life for some, and conversations about discontinuation of the same are viewed as mistrust. So really important to have a cultural assessment, which allows the healthcare team to really focus on the uniqueness of an individual's care. And care-related decisions must be made in the context of an individual's beliefs and practices, and of course, within the regulatory and ethical framework that exists in the area where all of these interventions are being delivered. Spiritual, religious, and existential aspects of care, again, every effort should be made to offer this support, really affirming the individual in the context of their lives, values, preferences, and instead of just the disease, is really important to support the whole person. Some of the interventions that can be talked about here are examples like life reviews, ensuring that individuals have had the opportunity to, resolve conflicts with their loved ones or say goodbye. These interventions help bring a peaceful closure and a sense of control. And some individuals or caregivers, they may choose to make, donations or share their experiences and knowledge. So whatever works for the patient or the family, let's provide them with those options. Ethical and legal, one of the, big elephant in the room, ability to issue advanced directives, outlining preferences about the use of life-sustaining treatments, or considerations for dignified death, which is, permissible in certain countries and not permissible in the others. All of these interventions should be considered within the context of the existent local or national regulatory, ethical, and legal framework. Social aspects of care, again, really important. Social support services can tap into the community-based resources and networks to deliver an integrated model. So coordination of post-acute care referrals, volunteer and companionship services, bereavement counseling, patient and family support conferences, all of these facilitate individuals as well as caregivers adaptation to, to various stages of illnesses through a social and emotional approach. End of life care is something, that palliative care gets involved with based on an individual's preference. anticipated trajectory as well as the expected symptomatology. All of these, should be discussed with the patients and their caregivers, whosoever they wish to be involved in their care. And plans for management for any decompensation should be put in place. An individual's preference about place of death, be present, all of those should be respected. And withholding and withdrawing of life-sustaining treatments such as foregoing ventilatory support, ICD deactivation, inotrope discontinuation, all of those can be discussed as appropriate within the contextual, legal, and ethical framework. In United States, we have a differentiation between palliative care and hospice in the sense that palliative care involves hospice, and not all hospice is palliative care, but palliative care is the bigger umbrella, which involves hospice-like interventions. So hospice in US is insurance benefit, which is there for patients whose expected life, whose expected life expectancy is 6 months or less. So in those instances, patients can choose to be at home, and a multidisciplinary team can go to these individuals' homes and offer the same interventions, but now these interventions are delivered at the place of a patient's or a caregiver's choice where they want to be. So whether they want to be at home or if they decide to be in a facility, and essentially they provide symptom relief medications, any supplies that may be needed, for example, hospital beds, supplemental oxygen, commodes and things like that, where patients now can no longer get up from their bed and go and use the restrooms. So all of these supplies can be brought in by the hospice team. There's 24/7, 365 support available to these patients. And hospice, generally what they do is they continue to make evaluations whether the disease is progressing, yes or no. So in certain instances, let's say if the patient stabilized with good symptom management and with good hospice care, there are patients who come off hospice, but that that volume is very very little. Most of the patients tend to pass away. So essentially the secret recipe over here is timely interventions, treatment of symptoms, coordinated care, establishing a support and safety net, and really skillful, communication. And some of the public health measures milestones that were interesting that I saw was that the national list of essential medications now involves, not only medications, but even stents were added to this list in 2016. And essential diagnostics list now includes ECG, echo, CT, MRI, and angiography. So which means that all of these interventions can now be available at the local level as opposed to tertiary centers only. And more importantly, the goal here is ensuring that an individual is able to live a good life right to the very end. As Dr. Atul Gawande, who's the author of Being Mortal, has put it in beautiful words, that our ultimate goal, after all, is not a good death, but a good life to the very end. And that's all I had to say for the presentation. And I'm going to stop sharing my screen.
Thank you, Dr. Puneeta. Maybe we'll take a few questions after Dr. Shoba's presentation. Dr. Shoba?
Hello, good evening. I don't have a presentation. Puneeta and I had decided that Puneeta would do the presentation and kind of summarize what she said right now. I hope I'm audible.
Yes, you are audible. And we can have more interactions once you shared your ideas.
Yeah, sure. So what she essentially said was, you could see from her presentation that in India, different states like Kerala, Punjab, etc., are more riddled with cardiovascular diseases, probably related to lifestyle I would think so. These are areas that we need to focus on. But if you look at rheumatic heart disease, that's not so prevalent in Kerala. But other diseases that specifically ischemic heart disease, etc., is very prevalent in Kerala and Punjab. So different cardiovascular diseases are prevalent in different states in India. You can actually go to the site and have a look. Depending on which state you practice, maybe you can, gauge like what kind of diseases are common in your own towns and cities. And what she said was basically
Your voice is breaking in between. Sorry.
which she has highlighted in that wheel which she showed. And I'm sure like you would have had different classes.
Ma'am, your voice is breaking in
Yeah,
between.
I'm on hotspot. My internet is down, so bear with me, please. If you have not heard anything, can you put it in the chat so that I can speak again? All right. So that's what I said. My internet is down. I'm on hotspot. Hello? Hello? Am I audible?
Yes, you're audible now. Yes, yes, you are. Last part we missed, last part a bit because the voice was breaking.
This is hello.
Yes.
You were talking of the heart failure which is refractory only, or refractory cases, because you have already tried the routine management and then only you go for palliative care, right?
No, so what we have started, the model that we have started integrating is when somebody has, starting to develop, congestive heart failure, at that point in time, of course, the care is usually managed by the primary care physician or with the cardiologist, depending upon what's the reason for, heart failure. And once, the patients start getting symptomatic, that's when, we generally get involved. But the ideal time, and again, this is a mindset change where, I don't think patients are going to want to hear from a palliative care physician the first time that they are diagnosed with a heart disease or with, with congestive heart failure. So as, the disease starts becoming a little bit more burdensome, where they're now having more hospitalizations or their symptoms are getting worse, that's the practice that we've seen here. That's when palliative care teams start getting involved.
But that means it is not correctable by the cardiologist then only. Is it that way? Because
no, we get involved along with the, generally the practice is,
with, right? Go ahead. You are integrating with the active participant cardiologist also. That's what I can understand.
Yes, correct.
The same thing we do with cancer patient. Right.
Correct. That's the mindset that's changing now, that, integration of palliative care is not just for, oncological diagnosis only, even neurological diagnosis, cardiac diagnosis,
everything.
Respiratory diagnosis. It needs to be involved early on. Not the first, consultation that an individual would want to see, but, when the symptoms are becoming burdensome.
Thank you.
And another thing that we've seen is that, generally for example, the cardiologists or the pulmonologists, they may not be comfortable using, opioids for the management of, advanced dyspnea or advanced pain. So usually, when they've exhausted their medication chest of, the disease-directed therapy, so the medications for heart failure, like your diuretics and the ACE, the ARBs, and all of those things. And now if it's coming to, where opioids have to be considered, that's when I've noticed that, they will transfer or they will call us for involvement. If now patients are experiencing, anxiety, depression, that's when, they'll call us.
What is the dosing of your opioids? 4 hourly, 6 hourly?
Sorry, can you repeat the question again?
Your dosing of opioid and having a bad throat, is it 4 hourly or 6 hourly? Sorry.
It depends upon the symptoms of the patients. For some, short acting, maybe 4 hourly, 6 hourly, but patients who are becoming more symptomatic, in those cases, or if their symptoms are not adequately resolved, we may need to go up to as early as 2 hourly. And in those cases, generally, then what happens is then we start something long acting on the back end and deal with the exacerbations with the, with the short acting opioids. So let's say I see a question here. Could you explain about the use of opioids in the outpatient setting for heart failure patients? So, let's say you used your diuretics, you used your ACE inhibitors, you used your ARBs, you used all of those medications, and you're still symptomatic, you're not ort to maintain your activities of daily living. Then in that case, you see whether patients are still short of breath. And if they're using, they're speaking in small, short sentences, they're not able to, even talk properly. In those cases, small dose opioids, morphine, those can be introduced. And then depending upon the frequency of how frequently they are using, if they're using it, more than 4 to 6 times a day, then in those cases, long acting opioids along with short acting opioids can be used. And generally towards end of life care, we've seen that when patients have really, really advanced heart failure and nothing else is working now, because now their blood pressure is low, they have what is called as, cardiogenic shock and cardiorenal syndrome, where kidneys are failing, you're not able to maintain your blood pressure, and you are still tachypneic. So those patients may get admitted for just symptomatic management, and they may require a continuous IV infusion of opioids. Anxiety is a big contributing factor. So, we do use benzodiazepines for those cases. So that's a concomitant symptom that virtually exists. Somebody wrote about the Seattle heart failure model. Yeah. So Seattle heart failure model, yes, is, existent, and it predicts mortality, if you, in 5 years or in 2 years, 5 years, like that. But generally what I've seen is that, risk of repeated hospitalizations, that's kind of like one of your best indicators. Like, for example, you have a patient who comes in now and then, could not even stay home for a week, and now they are back again. I feel, or at least in my practice, what I've seen is that's the best predictor of mortality, repeated hospitalizations. Hyponatremia, S3s, all of those factors that we talked about, those are there. But generally, these models, they provide you what I would say is a guesstimate, not an estimate, but a guesstimate, where yes, you can talk about the numbers, but then numbers are numbers. You look at the patient, and if this individual is severely declining functionally, if this individual is having repeated hospitalizations and is no longer able to manage themselves at home, that's one of your best predictors. Long-acting medications, yes, means sustained release preparations.
Any other questions before we can move on to case presentation? There is a question on children with heart failure. I think it's mainly to deal with parents when it is a child with heart failure.
Correct. So that's one of the hardest parts when you have children with heart failure. Not only, you're managing the child, but more importantly, you're managing the parents as well. Really, taking the time to sit down with them and skillfully communicating about what are the interventions or disease-directed interventions in consultation with the other specialists who may be involved with the care of the child. What is realistically going to be possible, yes or no? And if realistically there is something which is not going to be possible, then in those cases, talking about the anticipated course of what may lie ahead and what can be done to manage that decompensation moving forward. What are the support systems and resources that are available to the child as well as to the parent? So communication, communication, and communication is the #1 intervention, which is, yes, it's needed for all patients, but even more so in these situations.
Medications to withdraw at end of life care. What cardiac medications?
So I'll give you an example. I recently was involved with an intervention was called in for somebody who had severe aortic stenosis. So this individual was diagnosed with aortic stenosis, I think about maybe 6 to 8 years ago. Initially, they did well with all of the medications that were being prescribed by the cardiologist. But then over time, they started developing heart failure. So interventions now became directed more towards optimizing the heart failure. And at that time, the stenosis was not severe enough where it warranted surgical interventions. And now what happened is that, as heart failure became more, and the patient was not really interested at that point in time in pursuing any surgical interventions also. So over time, this aortic stenosis progressed to the level where it was severe and then critical. And as a result of that, the ejection fraction continued to drop and drop. And there were conversations with the patients before about what would they want about their advanced directives and what would be their goals. And at that time, patient wanted to continue with whatever medical interventions that were available. And wife was designated as the surrogate decision maker should this individual not be in a position to make decisions for themselves. So there were 2 or 3 hospitalizations in between. And now with the last hospitalization, this individual came in cardiogenic shock, cardiorenal syndrome, was hypotensive, tachycardic, and they had to start pressure-induced diuresis. So patient was on Levophed, norepinephrine, along with Lasix infusion. Obviously could not tolerate beta blockers or anything else that could be done. So with that, the forward flow increased a little bit, and patient was eventually able to come out of norepinephrine. But what happened is, as soon as the norepinephrine was withdrawn, the blood pressure started dropping further, because again, there is no pumping action, or there's not enough pumping action to direct the forward flow. So interventional teams, the general cardiology teams, heart failure team, they saw the patient and they discussed that at this point in time, valvuloplasty could be considered, but it does not guarantee that it's going to work. And what complicated the situation here was that this individual in between suffered, had other conditions which really impacted their ability to get a valve replacement. So at that point in time, there were other conditions that happened, and he just could not, get that valve replacement early on. So now that it was a situation like this, the individual we sat down with the patient and we said, okay, what matters to you the most at this point in time? We understand that the valve replacement cannot be done. Valvuloplasty can be offered, but again, it has no guarantee that it's going to work, and it's only going to give you a transient relief. The individual discussed it with their, family and decided, they would not want to spend the rest of their lives in the hospital and connected to, ventilators or, getting resuscitated. This is not what they want to do. And the individual decided that he is going to go home. So in this situation, what we did was all of the inotropes were withdrawn. Lasix, what we discussed was that as long as patient is able to tolerate oral medications, we will continue. So diuretics were continued, statins were continued. Beta blockers could not be given. Essentially, nitrates could not be given. So the only medication that the patient was on was diuretics and the statins. And what we introduced is a small dose of morphine on a PRN basis, so that in case the patient became dyspneic or experienced pain, then in those cases this could be used. And the way our system is set up here, individuals are very we have put parameters in place to monitor the side effects of medication, so people can use the opioids as frequently as depending upon the system that you have, or depending upon the symptom that you have. Individuals could use it every 4 hourly, 6 hourly. We gauge whether symptoms are being adequately treated. If not, then in those cases, morphine could be used as frequently as 1 hour frequency as well. So now the individual is being prepared for discharge home with hospice services, and where they will be able to get supplemental oxygen. They'll be able to get the hospital bed so that movement is not that difficult, and they'll be able to get a bedside commode so that if they can still maintain some degree of dignity and not just pass stools and diapers, as long as that's possible. And the family is also hiring somebody privately to be with them 24/7 so that they can help with all of the activities of daily living. So what we also did was, for anxiety, we introduced Ativan, lorazepam, and we introduced it in a small dose, 1 milligrams, to be used every 4 hourly or 6 hourly as needed to begin with. And once you see a constant usage, that an individual is using it or requiring it frequently, then you can change it to a standing dose. So if somebody is naive in the use of these medications, we just don't start it on a regular basis like that. We start it on a PRN basis, and then from there on, depending upon if they use it very frequently, we may switch it to a standing order. So if morphine started, should we continue with other cardiac drugs? It totally depends upon the individual situation. If you have somebody who is able to take it and the drug is not causing more harm, you weigh the risk versus benefits. So if something is not causing more harm and is not burdensome, that is something that can be continued. And if it's if it's changing the outcome, yes, you can continue that. For example, diuretics. In these situations, whatever fluid that they can get rid of, if that works, they can continue to take it. But let's say if now the individual becomes, impaired cognitively and is not able to swallow medications, in those cases, then, we're not going to continue oral diuretics then. So totally depends upon the situation. And that's why we have this hospice team, who can continue to make that determination and adjust the medications based on the individual situation.
There are a few more questions regarding anxiety, and melatonin is it useful?
So melatonin generally, in some cases, I found it useful that it works. In some cases, like for example, in situations where really you are short of breath and you're not sleeping, in those cases, it may not work. So it's really an adjunct, and you have to address these symptoms from a multi-modality angle. And you see what works or what does not work. Something may work initially, melatonin may work initially and may not work towards the later stages. And in those cases, more intensive interventions, like, for example, if you're not sleeping because you are propped up, because you're short of breath, then in those cases, opioids are indicated. And the reason then opioids are given over there is not for insomnia, but it is for your shortness of breath. But they do induce sleepiness. And generally what happens is that, as the disease advances, then as a result of the biochemical changes that are taking place inside your body, encephalopathy is going to ensue. And eventually, you're not going to be as awake.
Thank you, Dr. Puneeta, for answering all the questions. There can be more questions, but we'll move on to the case presentation, and maybe related to that, there can be more discussion.
Mm-hmm.
Good evening, everyone. Am I audible?
Yes, Dr.
Yes,
Singh.
Dr. Sir.
Thank you. So my name is Savitri. I'm currently not working anywhere. I used to work in a secondary care hospital in rural Chhattisgarh till last year. And the presentation that I'm about to make is of a patient that I met there. Can you go to the next slide? So the patient is a 62-year-old male who was diagnosed with congestive cardiac failure secondary to ischemic cardiomyopathy. So I would just like to mention that this is a patient I met more than a year back, and most of the details I've sourced from my memory. So I apologize for any missing or illogical details. Thank you. So the presenting complaints, the patient had an exertional dyspnea of NYHA class 3. He had bilateral pedal edema, abdominal distension, and inability to sleep at night due to severe shortness of breath, that is breathing difficulty. The symptoms had gradually worsened over the past 1 year. So the history of the illness is that the person was diagnosed with hypertension approximately 10 years back, but he used to consume medications only intermittently because he could not afford them always. He used to have intermittent episodes of chest pain, which were worsened by activity and relieved on rest. He suffered an episode of acute severe chest pain that could not be relieved by rest 1 year back. And he was rushed to a nearby hospital and received oral medications and some injections. He felt better in a week and went back home. And he did not follow it up with angiography or any other treatment. Since then, he noticed that he had an even more decreased exercise capacity and intermittent episodes of paroxysmal nocturnal dyspnea. Over time, he developed edema of the feet, abdominal distension, and severe breathlessness on lying down. So this significantly affected his ability to sleep at night, making him irritable and short-tempered throughout the day. He sought many treatments from small private clinics and government primary health centers, where he was advised repeatedly to go to higher centers. So on examination, the patient was alert, conscious, and oriented to time, place, and person. He was comfortable sitting up on bed, but severely breathless on lying down. His pulse was 90 per minute, regular in rhythm, and a blood pressure of 150 over 90 millimeters of mercury. He did not have any pallor, icterus, or lymphadenopathy. He had severe bilateral pitting pedal edema with a raised jugular venous pressure. Abdominal distension with ascites is present, so there was fluid thrill and shifting dullness. Hepatomegaly was not appreciated. Bilateral creps could be auscultated, which was suggestive of pulmonary edema. So the investigations, the relevant blood counts and hepatic and renal profile were within normal limits. An ECG was suggestive of ischemic heart disease. An echocardiography was done, which suggested reduced ejection fraction and decreased LV motility. So along with the history, it was suggestive of ischemic cardiomyopathy. We started treatment of injection of furosemide, tablet enalapril, pantoprazole, spironolactone, metoprolol, and therapeutic abdominal paracentesis. Psychosocial aspects. The person was working in a minor clerical position, but was retired when he presented. Since his symptoms had worsened, he had become increasingly unable to sleep, making him very irritable during the day. He was often short-tempered with his wife, and that led to tensions between them. During the hospital stay, he wished for his sons to visit him, but they worked in different cities as laborers and were unable to visit, which upset him. Over time, he became delirious, often speaking to himself or shouting at his wife and the other patients nearby. The nurses too found it very difficult to manage him. The medications that he was on eventually were injection haloperidol on SOS basis, injection furosemide, enalapril, pantoprazole, spironolactone, metoprolol, aspirin, and therapeutic abdominal paracentesis when needed. The main concern was to tell them, to communicate them about the poor prognosis, to treat his delirium and insomnia, which was a resultant of the orthopnea, and to plan for his further treatment after the hospital stay. That is basically to find an affordable home-based comfort care for him, which was nowhere in sight, given that he lived in a village in Chhattisgarh. The summary is he's a 62-year-old male person with chronic congestive heart failure, secondary to ischemic cardiomyopathy, with insomnia and delirium. So most of my query regarding this person's case was related to the insomnia and the delirium, which to me seemed to be secondary to the orthopnea. Thank you.
Right.
Thank you.
Thank you, Dr. Savitri. I'm Dr. Shoba here. Thank you. I'm sorry for the technical glitch. Sridevi, I'll just take this from here.
Yes, sure, ma'am.
Yeah. Right. So thank you for that excellent presentation. You've put things in perspective. So if we can divide this patient's different domains, like for example, physical, psychosocial, and spiritual. The spiritual aspects probably have not been explored that we can see. And also the medications that he was on, did you start these medications on your own, or was he on these medications when he came?
We had started these medications.
All right, okay. And you found improvement with these medications, or still continue to have orthopnea, could not lie down completely, is it?
He could not lie down even on these medications.
Right, okay. Was metilazone considered at any point, Dr. Savitri?
It was not available, ma'am.
Available at that time, okay.
Yeah.
So from what we have seen is when you give a combination of loop diuretics with metilazone, the GFR is not so much affected with metilazone as it would get affected with other thiazides. So it could be helpful in such situations in very small doses and can drastically improve their quality of life, is what we have seen and experienced during medical training, and also seeing these patients who are referred to us. Right now, we have a child who is 8 years old with dilated cardiomyopathy, who is with us at the moment, or referred to us under pediatric ICU. He's kept in ICU because he becomes breathless in between. So I was just thinking about that. So first and foremost, like Puneeta said in her presentation, we need to optimize medications. So were you giving furosemide, IV furosemide, and what dose?
I don't quite remember it.
Remember, okay.
Yeah.
That's fine. That's absolutely fine. So what we can understand in such situations is if people do not have access with IV route, we can definitely start a subcutaneous route with Lasix. Okay, diuretic Lasix can be given subcutaneously, and we can start with 80 to 120 to even go up to 200, 250. We've given it subcutaneously in our practice, and IV, of course, we might need to give higher in the sense like 250. So the same thing can be given subcutaneous doses. The same conversion. You don't have to triple it or anything. But the problem with these patients is that they might have pedal edema or anasarca towards the end. So how much amount of medications is absorbed is anybody's guess. And also to get IV line is so difficult. And therefore the optimization becomes a huge problem. So definitely we can try IV to make him comfortable so that he can lie down and go to sleep. Because I think you had said that his insomnia was a major concern, and that was secondary to orthopnea, right? And because of the hypoxia, he might have had delusions and delirium. And like Puneeta said, you can go in with hypoxic encephalopathy. So in order to provide oxygen to those tissues, we need to have diuretics in place, and of course oxygen supplement. Was oxygen also given to him?
Yes, ma'am, it was given.
Oxygen was
I'm
given.
not mentioned in the present.
Yeah, okay. I suppose we generally don't initiate digoxin because we don't have so much of expertise, because definitely when they have come to the hospice kind of a situation with orthopnea and dyspnea, definitely we can initiate diuretics. And I see that you've given metoprolol, enalapril, aspirin, etc. And you would have stopped probably these medications when you couldn't take anything more orally?
Yes, ma'am. Yeah.
Right, okay. And the other thing is to initiate morphine, which definitely reduces anxiety along with lorazepam, what Puneeta was talking about. So morphine, first and foremost, it reduces anxiety in these patients, in cardiac failure, respiratory failure patients. There's been a lot of literature on the use of morphine in these patients, because we know that it prevents or rather it produces venous dilatation more than anything else, and thereby reducing the preload also. Okay, and it eases the pressure on the heart for its contraction, is what we're told. But a lot of papers say that these results are not so significant per se. And there's a lot of studies on mortality caused by morphine use in these patients. But I think we need to overlook those kind of things in such patients when they actually reach this kind of a stage where we can initiate morphine on a very low dose. Like right now, the child with us, we have initiated him on 1 milligram SOS. And as and when he starts taking it 2 or more times in a day, we're going to have a steady dose. A steady increase in the dose. So there is no hard and fast rule like how many times we can give. We can give a continuous infusion, either IV or subcutaneous in such patients, a very small dose to begin with. Like for example, 5 milligrams is probably 4 hours. If you're comfortable with it, it's just you're gauging the situation to it. So that was one thing which maybe you initiated. Did you do that, Savitri?
Again, for morphine also, we did not have it available. So.
Oh, it was not available at that point in time for already. And what about lorazepam? Was it available?
Yes, lorazepam was available.
Was it given sublingually or just?
No, we had not given lorazepam.
Given sublingually, yeah. Okay, so that it can be given. We have even given it every 2 hours for some patients who are very, very anxious with breathlessness and things like that. So I'm not saying that you should try that straight away, but definitely a TID dose, a small dose to begin with, if you're not sure, like 0.5 milligrams sublingual, and on an SOS basis to control the symptoms. So the hypoxia bit, which causes delirium, and you had given haloperidol SOS, so why not on a regular basis, like a BD dose?
Okay, we were a little reluctant to use it, but that is perhaps what led to the SOS dosing.
Yeah. So I think depending on the weight of the patient or requirements and the severity of the symptoms, we sort of initiate 2.5 milligrams IV towards entering end of life, that sort of thing, or even without that, like BD dose and on an SOS basis, so like during COVID situation, we had even started haloperidol, 10 to 15 milligrams as a continuous infusion, IV infusion over 24 hours. So the symptoms of dyspnea and insomnia and delirium, we can definitely optimize with different medications. That was one aspect, the physical aspects. And then you were talking about psychosocial aspects, isn't it? He didn't have so much money to take treatment initially. And that led to his deterioration very quickly. And his wife was also upset. So did you address his wife's concern? I'm sure that you would have done that.
Yes, we had spoken to her and tried to explain to her that this is a disease which is causing him to behave in this manner. But of course, she was really upset about it.
Yeah, that it's useful to explain to people that's because of the hypoxic delirium that he's probably speaking like this and shouting at his wife and so on. So helping her a bit, that would have helped. And also, I'm sure like you would have provided these medications free of cost. Was it free of cost? Or some help
Sorry, ma'am,
from someone else? No, did you give these medications free of cost? Was treatment free?
Yeah, our hospital was covered under the government insurance. So
Yeah,
we did not have to pay anything.
Right.
As long as he was there.
Yeah. And then one of the other things that we overlook in delirious patients is constipation, Savitri. So did this patient have constipation?
I think he did.
He did. So
we did have a habit of prescribing laxatives to patients with heart failure to prevent them from straining and worsening the symptoms.
Yeah. So of course, this delirium is first and foremost because of the hypoxia and not able to sleep and things like that. But on top of it, this can also add to the delirious bit. And also, you're also mentioned about paracentesis. So as you can see, when people have ascites, their bowels become more sluggish. And so laxatives would definitely help in these patients. Of course, this is not the time to explore spiritual aspects of, if you had seen this patient before, maybe we could have had a conversation like that with him. So he was not in a position to have that conversation. Anything else which you would like to cover, Puneeta?
Correct. So thanks, Shoba, for the broad view and, really stressing upon the importance of, looking at each and every single contributing factor that may be, impacting the or influencing the symptoms. So as I heard through the case and as I heard, you talking, what I was thinking about is, one is what can be done acutely to kind of like help relieve the symptom. And then what are some of the, long-term behavioral changes that are going to be, needed in order to be able to provide adequate relief? So immediately, as I was thinking through this is, optimizing the medications, as you pointed out, whatever can be done to optimize the underlying disease, because that's going to prevent the progression of the symptoms. So that's number one. And number two, paracentesis, because the abdomen is bulging out, that's compressing your lung capacity, that's predominantly contributing to your inability to to sleep. So immediate paracentesis in that situation would be helpful. Now, I don't know, what was not clear to me was how big was the abdomen, meaning, was it large amount of paracentesis, in which, large amount of ascites, in which cases, in those cases, large volume paracentesis may be needed. And one of the complications that happens in that situation is when you take out, a large amount of fluid, is hypotension can ensue. So which may limit your ability to use heart failure directed, medications. So over here, what we have used in those cases where large volume paracentesis is expected, and that's defined as more than 5 to 6 liters of fluid being, being removed, we have used albumin infusions alongside to maintain the oncotic pressure. So you're getting an albumin infusion, and then you get a paracentesis catheter, and in the meanwhile, the ascitic fluid is being drained. In certain cases where you have refractory ascites, we have even put in indwelling peritoneal catheters. But again, that's a risk versus benefits discussion with the patient and the family, because again, this is a foreign body which is penetrating, right? So risk of infection and all of those things are are important considerations here. But again, weighing the risk versus benefits as to what matters more in this situation. So that's one thing that I was thinking about. So that's kind of like the short-term, intervention that you could do. Long-term wise, I mean, CBT kind of interventions. And first part of that CBT intervention is really having a clear communication with the patients and the families. And this is after, of course, the patient's not going to be able to understand if the patient is delirious. So once these acute things where, you've done your oxygen, you've taken the fluid out, you've optimized the decongestive therapy, then really establishing a stable bedtime and a wake time routine. We often forget the importance of maintaining a sleep hygiene, right? How many times are we sitting in the bed, watching TV with that screen, kind of like messing up with our, with our circadian rhythm? And then we say, we're not able to sleep, right? So really having a proactive discussion about how, there is a need for maintaining this sleep hygiene is really, really important. Then reduction of the time in bed to approximate the total hours of estimated sleep. So meaning if you're not able to sleep, you just don't keep lying there staring at the ceiling, because that's going to just aggravate the problem further. So in that case, get up, move around if you are able to, and use really the bed for, when you're really going to be sleeping. Additional things like avoiding, substances that interfere with sleep, like, caffeine and things like that. So those should be, considered. And then avoiding naps in the day. If you're not able to sleep during the night, then avoiding those naps during the daytime, and making sure you have a comfortable environment where you can now sleep. So it's not like overtly stimulating environment when you are lying down to sleep. Having a calm, comforting environment, doing some relaxating rituals before sleep, those are important important considerations as well. And then if all of those things do not work, then in that case you can move towards medications.
There is a question to Dr. Shoba about lorazepam, how frequently you can give lorazepam. Yeah, got the response in the chat that ma'am is telling you can begin with the TID dose and also write up for SOS. I guess that is for lorazepam dose.
Mm-hmm.
Yes, that's for lorazepam. If you're not sure, you can, just give one dose and, see how this patient is, how long he's anxiety free, or he's comfortable, calm, and composed. Some of them require it every 2 hours. We have had those kind of patients too. So to be on the safer side, start slow, start low, and then go up.
Thank you. Any other questions from other participants as well as from Dr. Savitri? So there is a question, does CPAP has a role?
So CPAP, I can take that question. So CPAP has a role in cases where, sleep apnea is causing the prime, problem. But also understanding that, it's kind of like difficult, with the mask, who wants to sleep with this tightened mask around your nose and your, around your mouth. So yes, it can, ward off your, blow off your CO2, but, it's not the most comfortable thing. So if the prime reason is, if you have sleep apnea, pulmonary hypertension, those kind of things, then CPAP, where issues with CO2 retention and where the mental status is there, CPAP is not good for patients whose cognition is not, totally there. We may actually worsen the situation. It's kind of like restraining the patient. And I've seen that, patients, if they're delirious, they're not going to benefit from, they're not going to benefit from CPAP. That's going to further exacerbate their delirium.
Thank you, Dr. Puneeta.
So can I just
yes,
summarize a bit in the sense, so Puneeta can add in if I've left out anything. What I mean, what the purpose of this class is not to sort of make all of us a cardiologist, but to understand that these medications are given to such and such patients, and to check whether these medications are on the optimum dose, to monitor their blood reports, check for sodium, potassium, etc., and make sure that they're functioning. In case, I mean, I'm sure like a lot of you would be going for home care. For example, from Palliative itself, you go and see a lot of non-cancer patients where you might come across this huge list of medications. Just make sure that the doses are optimum and these patients are taking it, they're compliant with it. So that's one thing. And also periodically check the electrolytes, because that's what gets deranged with these patients, and give them sufficient warning and speak to the relatives, making sure that these kind of things can happen, whether they want to go to the hospital or not, like advanced care planning, which is kind of not so prominent in India, but I think we're getting there. People have started talking about, are starting to talk about such things, which is really good. And also the important thing about deactivating the defibrillator and those kind of things, which Puneeta mentioned in the first session. So if you look out for certain areas and make sure that we've, tick that box and we've done this. And then of course the psychosocial sessions where you communicate with the relatives and tell them that this is what it is. I think that sums up the whole thing. That you can support them either at their homes or as an outpatient. And someone was asking about the question about outpatient morphine. We do prescribe outpatient morphine for COPD patients, and they're quite good with it and they stick to it. We normally start on a very small dose of 2.5 milligrams DID, and then we work our way up if they require more. But yeah, it really works. And the oral morphine can be given as an outpatient from the outpatient center. So that's what I wanted to say. Thank you.
Thank you, ma'am. This is Dr. Deepak here. May I just ask a query?
Sure, go ahead.
Ma'am, so this was a case which I saw in home care in Kerala maybe a week ago. So he's a 54-year-old with coronary artery disease and a chronic lung disease, uncontrolled diabetes and hypertension. And he's on 4 medications for his hypertension and 3 medications for his diabetes. Now, because of certain financial issues and social situations, they were unable to, they stay in a very remote location. It's very difficult to even reach the house. And they were unable to even take the patient to the hospital due to various reasons. Now, this patient has been having a blood pressure which is always in the range of maybe systolic 80 to 100 and diastolic 60 to 80. He's having, frequently he is going into hypotension and falling. But at the same time, they are unable to go to the hospital due to various reasons. Now, I was wondering that how safe is it for me to start adjusting his medications and how to go about it in a home care setting? If you could throw some light on how I can practically deal with this situation. And this is just one example. There are many like these. Due to certain issues, we are unable to address it the way it needs to be addressed. Of course, it would have been easy to have a cardiologist on call, but it is not so. The situation right now is not so. So how do we go about this? Like for people like palliative care physicians like us who are on the field most of the time dealing with these kind of patients, like what guidelines do we follow? Is it the usual AHA guidelines, or how do we titre their medications? Is there anything else which we can do? I would much appreciate if you could throw some light.
So let me say a few things and then Puneeta can add. So in Bangalore, there's a hospital called Baptist Hospital, and they're very good with home care, and they do end of life care at home. So they actually start the syringe pump, which a lot of us do. But what they do is they take a consent form, right, for initiating these medications at home. The same thing can be applied in situations like this where they don't have access to hospital and you're forced to actually take a call and adjust their medications. Maybe you can, get in touch with your seniors and probably do that. Or if there is a cardiologist friend or general medicine friend that you know, if you're not sure like how to adjust these medications, then that can happen. But you need to inform, as you would, Deepak, I know you, so you would definitely talk to these patients, relatives, and say, this is the best that we can do at this given circumstance, that you're not able to take him home, but there might be risks associated with it, then we are informing you about that. I'm sure like you will be doing that in the first place. That's first and foremost. Second thing about medication adjustments. Diuretics are a little tricky, isn't it? When the blood pressure is like 80 and 50 and things like that. What we need to remember is whether it is LVF, RVF, or CCF and those kinds of things. And so there's a bit of reading that we need to do. And diuretics can be, tried, and sometimes the pressure comes up in different left side or right side of heart failure. And so if you are in doubt, of course, you can make an adjustment. You of course do a bit of reading. When you're regularly seeing these patients, you become an expert, and that's how medicine works. And also get guidance from a senior faculty on like just a phone call away. And I think that would be the best way to go. HA guidelines, how practical it is in our country, and how, like Puneeta was saying, so these are the guidelines, HA guidelines, but how is it practiced in India? Maybe you can, get a cardiology friend to talk to you about it, and then go about it. Puneeta, do you want to say anything?
So, first and foremost, I just want to say that I can appreciate the challenges that are existent with, with not having an infrastructure around in place to be able to manage these patients at home. I think that's the biggest challenge here. So, the stark comparison, sort of like, here, if this was the situation that I was encountering with, is, it seems like the patient with a heart condition who is now not able to manage that blood pressure could be because of one of the two reasons. One is there something acute that's happening that's contributing to all of this? Didn't look like that there was an acute decompensation, like an infection or something. Seems like this is kind of like the chronic progression where, the pumping action itself is failing. So in which case, how we would have dealt it over here is definitely, this is not a situation that could have been managed at home. The patient would have been brought to the, to the hospital. And what we would have used over here is diuresis, which is supported by pressors. So, and even, albumin infusion. So to kind of like support the blood pressure. So that way, you are able to kind of like get into that balance where, you're maintaining the blood pressure, but at the same time, you're getting rid of that extra volume also. Now, having said that, if let's say the patient is not able to come out of these situations, in those cases, we've used, inotropes like milrinone, and patients have gone home on those infusions where now they are able to, manage those infusions at home with support from home care. That's the kind of like infrastructure that we have here. Now, if let's say, milrinone could not be, could not be handled at home, and patients did not desire to be on this kind of like continuous infusion, in those cases, then they opt for hospice. And essentially at that point in time, then we are not using any medications. So it's just totally, the care is totally based on symptom management, which is, shortness of breath, then we're using, opioids. Anxiety, we're using benzodiazepines. Again, shortness of breath, again, pain, or it's all opioids. And if there is delirium, then, appropriate delirium treating agents. So that's how we manage this sort of a situation in this part of the world. So it raises a good point about, being advocates for, or, ensuring that you're supporting, other groups who are advocating for improved infrastructure to be able to deliver this kind of care at home. I cannot even imagine like how you would manage this at home, because there's no parameters with which you are working through here. You give diuretics, you don't even know which direction the blood pressure is going, yes or no. And financial support, I can tell you, most of the insurance on this side of the world, either it's employer-based insurance, or if people who are 65 and above, they have, national insurance, which is Medicare. So anybody above 65 who's a resident and, meets certain criteria, they have Medicare with it. And as a result of that, at least the cost of your basic hospitalization and all those things are, covered. Not having those kind of like resources in place makes it a real challenge. And so, really having a list of resources in your, in your chest about what are some of the, funding organizations who would be willing to cater to the needs of such kind of situations is important. Again, nothing that gets done in one day. It's, it's a step after step. And, I think with all of you being present here, listening to all of these challenges and presenting all of these challenges, hopefully, it sparks further action to be able to, eventually develop that kind of an infrastructure where you could manage these situations at home.
Thank you so much, ma'am, for showing the big picture where it should eventually reach. I hope that we all are working towards it in one way or another. Thank you so much.
No easy answers here.
Thank you so much, everyone. Thank you so much.